ايه الكلام ابتدي امتى؟ Morning, afternoon. So when should I start? Are we waiting for someone or just you go ahead and start? Go ahead. Okay. So nice to meet you all. My name is Wael Mohammed. I'm a GI fellow, and it has been a pleasure working with almost all of you throughout the year. I know this time of the year is kind of like a little bit boring for everyone. First years, taking care of, they are the primary contact all the time. And I believe by now you should be, like solid, like knowing the system, orders, everything. And from now on, you should have like a plan for the upcoming 2 years. What's going to be your plan? Applying for a fellowship or just, going forward to start like an attending job. Second years, almost there, like they should be ready by now, with all the research if applying. And by the way, you guys did great in the match season. You are awesome, like, great matches everywhere. And third years should be now ready either to like start fellowship in few months or start doing an attending job. And always think that, I know it's boring, time consuming, you are like spending, very long hours in the hospital, but just think about it. And once you're done with this, you're not well paid right now, just barely 3K or so. But I mean, in a couple of years, if you go with sound here via Christie, do 12 hours, you're going to be paid 2K within 12 hours. So from money wise, you should be doing fine. So cheer up. Okay, so this is one thing. And I know you're getting like, hard time contacting everyone, especially, this GI fellow who is refusing to see your consult because it's FOBT positive, and I forgive you. And high ammonia in a guy who is like with UTI or whatever with delirium, but, it's the only fellowship here and we are super busy as well. So thank you for, the time you're spending with us, but thank you so much. You're teaching us a lot and you are a great group of residents. I want to talk to you about like a couple of like few important concepts for the American Board of Internal Medicine exam and the ITE. And I'm going to talk about three important concepts. One is the pathophysiology of the IBD, Crohn's disease, and UC in details. You need to know this by heart. It's a little bit complicated. We're gonna like take 2 hours for this, but hopefully you're gonna like get a good grasp on that. The second one is gonna be the pathophysiology of the constipation mainly. Someone is bored already and leaving. And the third one is gonna be the Chicago classification for the echolation. Okay? Ready? I'm just kidding. You don't need to know any of this. So, when I was a resident, I used to have like, someone giving, a lecture, and usually they talk about like super duper complicated, whatever, or this like, rare case that you would never ever see in the future. So I always like, told myself, if I'm like doing a lecture, I want like one of two things, either someone teaching me something I'm doing every day, like, in my, like as a resident, or get me ready for the boards. And I thought about like, the board style. This is the bread and butter of American Board of Internal Medicine. As you know, not all the questions in the boards are going to be the same. They are going to be like different weights. Super duper easy, intermediate, or really hard. If you get the easy ones wrong, you're gonna be having a very low score, because most of the other residents throughout the country will like, get it right. So make sure to know this by heart. If there is a way you have this recorded on your system or something, when you're having lunch at some point, like before your American Board of Internal Medicine exam or the ITE, just, listen to this. Make sure that you can once you see the picture, you know the diagnosis. I believe we have a very good number. I want 3 groups. It's going to be a kind of a little bit competition. I want first years as a group, 2 second year as a group, 3rd year as a group. Can we do that, or that's going to be a little bit hard? But quickly. Yeah, let's go. And I believe the first years are going to get the highest score for some reason. So, and the 3rd years are going to get the lowest one. Hurry up, guys. We don't have enough time. So 3 groups, done? Done. I want a volunteer. Research fellows can go with the first year. No second years? Okay. I want a volunteer to have like a stopwatch. Can someone help with a stopwatch? Quickly, we don't have time. You're going to take care of that? No, it's going to be, you have it? Okay. For every question, you have 15 seconds to answer. 15 seconds to answer. Once it's time, you tell me time, okay? So, no. I want another volunteer with the score to write down the score. First year, second year, 3rd year. You got that? Okay. Okay. Are you a 3rd year? Are you a 3rd year? Yeah. 3rd years are sneaky, actually. I want like an honest first year. No, just kidding. Okay. So those are the rules. Number 1, if you get it right, you're going to get a point. You are allowed to say, I'll pass because I'm not sure. Or if you get it wrong, you're going to be -1. Is that okay? Okay, ready? No. It's going to be by turn. 1, 2, 3, 1, 2, 3. Okay? Where are the first year group? First year group? Second year? Small group. 3rd year? The beast. Okay. Okay, let's start with first year stopwatch and start. So you have a 28-year-old guy who has a history of IBS, inflammatory IBS, irritable bowel syndrome, new pruritic rash on his buttocks. What's the diagnosis? You can start. Is it acute generalized ecdanthomatous pustulosis, bullous systemic lupus, erythematosus, celiac disease, or a linear IgA, bullous dermatosis? Once you say yes, ready, go ahead. So you don't talk to each other? Everyone is okay? Okay. Okay, got you. Ready? Celiac disease, okay. Why celiac? Quickly to the point. You're right. This is like this. Yeah, I saw this on my USMLE step 3 and ABIM boards and almost 2 of my ITEs. So this should be easy, very common. Almost all patients with dermatitis herpetiformis, they will have a celiac disease, not the other way around. Not every celiac will have a dermatitis herpetiformis. So make sure you know this kind of like pruritic rash. So GI symptoms will be there in almost like 1/4 of those patients. Next, second year. 65-year-old guy, history of iron deficiency anemia. He had a normal colonoscopy, then we had an EGD done that showed this gastric lesion. I shouldn't point, but gastric lesion. What's your diagnosis? Is it acute hemorrhagic erosive gastropathy? It's a Delafoy lesion. Is it gastric ABM or angiodysplasia, or that's a peptic ulcer disease? Awesome. So 1.2 second year, that's correct. And this is angiodysplasia, very common on the boards. It's ABMs called angiectasia. Vascular ectasia means dilatation. It's ectatic, dilated, thin-walled vessels may occur anywhere in the GI tract and most reportedly in the colon. It comes, sometimes with the hereditary form, hemorrhagic telangiectasia, HHT. And by the way, everyone worked at Wesley. I believe you remember this guy who keeps coming every single month with GI bleed, a severe deficiency. And the prevalence increases with age. So it may be normal. It may be found in normal aging people. And most cases are completely without a clear cause. So associations, this is super important. On the boards, he's going to give you something on the history. Is either a really bad chronic kidney disease, 4 or 5, or von Willebrand disease, or aortic stenosis, which is called Heidi syndrome. And sometimes it's a little bit tricky. It may give you a guy with like advanced heart failure with an LVAD in place because of the continuous circulation causing those AVMs to happen. Okay, third year. You have a 50-year-old female. Here for dysphagia evaluation, we did a barium swallow, and this is at 1 minute, 3 minutes, 3 minutes, 5 minutes, sorry. Think about it. Don't jump to the easy peasy diagnosis. Confident third years. That's 6 seconds. Time is, if you don't answer, ready? Sorry? Achalasia. Yes. Why are you thinking a lot? Don't think a lot. Okay. You see, this is the problem when you know too much. At the third year, you keep thinking about the easy thing. Achalasia. It's a hypertonic motility disorder due to inadequate relaxation. Here on this barium swallow, you're going to be finding this barium kind of like stagnation, 1 minute, 3 minutes, 5 minutes, still there, doesn't move. And there is this stricture. So a classic dilatation of the esophagus, narrowing at the GE junction, which is called like a Burr's peak. And finally, there is no peristalsis or weak peristalsis. Causes either idiopathic, sometimes associated with autoimmune diseases. Specifically, sometimes we see it with sarcoidosis, happen like, some sclerodermas here and there, but different presentations, associated neurodegenerative disorders, and the classic Chagas. This guy who's coming from South America with blah, 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 common. Either like it's going to be a question from GI or CARS about dilated cardiomyopathy or this presentation. Easy to the point. One for all. First year, 32-year-old female, history, fulminant acute liver failure. By the way, when you call us anytime, acute liver failure, don't ever call an acute liver injury as a failure. Failure that I need to come some now, I need to call the transplant center. It's a big deal. Diagnosis based on severe coagulopathy or severe encephalopathy in a previously healthy guy with no history of liver disease. Okay, fulminant acute liver failure, history of hemolytic anemia, history of behavioral problems. What's your diagnosis? Is it alpha-1 antitrypsin deficiency, autoimmune hepatitis, hemochromatosis, or Wilson, which we call it hepatolenticular degeneration? Solid first year. Okay, who's saying easy? Third years? Okay. Okay. Wilson is super important for the boards, Kaiser-Fleischer rings. How can we do this? Can I go to the patient and see his eye like this? No, it has to be a slit lamp exam. It's circumferential discoloration. Mainly, this is a really silly question. Sometimes asks you, where is it? Is it the conjunctiva? Is it the iris? Most of the time when I was like a student, I got it the iris. No, it's not the iris, it's the cornea. Where exactly in the Descemet's membrane due to copper deposition, exam by slit lamp. It's super important. Associated with Wilson. Is it pathognomonic? No, it's not. Many other diseases, any liver disease may cause this. but when you see it, it's really important to suspect Wilson and you order the serology, copper amount, and stuff. Okay. Second year, 56-year-old female, chronic watery diarrhea. Otherwise, normal. You asked about weight loss? No, I'm good. Celiac disease was ordered. Serology is negative. Stool exam is negative. We did a colonoscopy and had a biopsy, and then this is the result. So is it C. diff? Is it Crohn's? Is it microscopic colitis? And is it UC? Start the time for the second year. Crohn's colitis. And now, first year. Yes. Okay, this is a microscopic colitis. This is important. This is important for exam, okay? Microscopic colitis, the presentation, chronic watery diarrhea, no weight loss, any IBD, most of the time they have weight loss, any cancer, weight loss. So middle-aged patients, more common in women, risk factors, NSAIDs, PPIs, smoking. There are two important subtypes, either lymphocytic or collagenous. This pathology is easy. You shouldn't miss this on exam. How can we see? This is severe inflammation with some, and then this is very important. Can you see this collagenous band here? Can you see this? Pale purplish throughout. This is a thickened subepithelial collagen band. This is collagenous colitis, which is a subtype of microscopic colitis. If it wants, so make sure on the biopsy, if it gives you intraepithelial severe lymphocytosis, this is the lymphocytic. The treatment is easy. Sometimes it asks about it. What's the treatment? Budesonide. Man, what if it fails budesonide? That's another, but this is for GI board. If it fails, you repeat the course one more time, and this is tricky. And sometimes asked about like holding the risk factors. NSAIDs, stop it. PPI, stop it. Smoking, stop it. PPIs, you stop it if there is not a clear indication for the PPIs. Great. The NSAIDs, PPIs, sometimes SSRIs, very important. Okay, third year. 33-year-old guy, recurrent food infection. Usually they come for some reason at 11 p.m. or 1 a.m. EGD is shown here. Okay, what's your diagnosis? Achalasia. Is it a cancer? Is it a diverticulum? Is it severe esophagitis? Third year, go ahead. You have MADI, so you should be fine. Ready? Ready. Stop. Okay, that's super easy. That's an EUE. Okay. Okay, EUE. The patients is like, wide distribution of age, second, fifth decade, more common in men associated with other atopies. This is going to be very important in the stem of the exam: asthma, rhinitis, dermatitis, seasonal food allergies. The presentation is going to be dysphagia. Usually, they will not call internal medicine. They are going to call GI right away. Dysphagia or a food bolus obstruction. On the EGD, what is this? This is we call it Farrow's. So either most of the time it comes in like this fibrostenotic, pathology because the farrowing, which is tagged, rings throughout, white specks, you can find this here and there. And then finally the mucosal friability. Usually you would pull the food bolus out and then take biopsies in order to send it for the pathology to make sure to have how many eosinophils. Third year, if you are not gonna answer this, are gonna have the point away, take away. Okay. First year, let's go. 29-year-old guy, history of nausea, non-bilious, non-bloody emesis, acute epigastric pain. What's your diagnosis? Is it autoimmune pancreatitis? Is it interstitial? Is it necrotizing? Is it pancreatic cancer? So it's a pancreas thing. No. Stop it. Third years. Is it time? We go with B, interstitial pancreatitis. Good job. Yes, that's a simple acute interstitial pancreatitis. So this is very common. By the way, when you get acute interstitial pancreatitis, do you call GI? Because I'm going to take the point away. Do you call GI for acute interstitial pancreatitis? No, this is internal medicine, bread and butter. Okay, acute interstitial pancreatitis. There is no necrosis. When it's necrotized, you can call GI, yes. They're not going to do anything, but still. Intact capillary network with vasodilation. What's the difference between acute interstitial pancreatitis and the necrotic one on the CT with contrast? It's going to be either having the contrast very enhancing. Why? Because of the acute vasodilation. Yes, that's correct. And now it's interstitial. On the necrotizing, there is going to be a lack of perfusion. And now you can say it's necrotizing. So here, this imaging, the pancreas is enlarged here. And then the contour is irregular. And then you're going to find the stranding and the edema surrounding. In the necrotizing pancreatitis, you can see this is like hypoperfusion rather than like hyper enhancement like this one. So this is important for you. Don't forget this. Second year, I'm going to make another mistake now. 33-year-old female coming with acute abdominal pain radiating to his hair back, associated with nausea and vomiting, appearing very, very severely ill. A contrast-enhanced CT is here. What's your diagnosis? Same answers: autoimmune, interstitial, necrotizing, and pancreatic cancer. Sometimes I may repeat the question, by the way. Okay. This is a final answer? Okay. Okay. Time is out. What's your answer? Like, that's final answer. Necrotizing pancreatitis, we just said. Okay. So necrotizing, don't forget this. No contrast, no enhancement. For the hemorrhagic pancreatitis, less likely you're going to get a question like hemorrhagic, but again, the fascial glands are going to be thickened. Hyperdense areas of hemorrhage are going to be there. So why this happens? A hemorrhagic pancreatitis, most of the time, is like severe complication of the acute severe interstitial one due to the proteolytic enzymes like eating the flesh of the pancreas. Good job. Third year, time for a mistake. 32-year-old female, chronic bloody stools and tenesmus. We did a colonoscopy, and then what's your diagnosis? That's a C. diff colitis, might be Crohn's, might be microscopic, again, as we told, or UC. Start the time. Three, two, one. Crohn's disease. Yes! Go first year. Okay, now second year are happy. Okay, that's a UC. Why not Crohn's? That's an IBD, correct, Mari, 100%. But the thing is that the only difference you can tell is all about the continuity of the lesion. So the UC on the colonoscopy, continuous pattern of inflammation of various severity. You're gonna find, this is like, not the best imaging, but I mean granularity, edema, friability, ulceration, but loss of the normal vascular pattern. Make sure that you know the normal, because when you see the abnormal, you know the difference. This is a normal colonoscopy. This is the vascular pattern that we see all the time. This is normal. This is abnormal. Do you see the difference? And then usually UC would have like involvement of the rectum. It may extend proximally in a continuous manner, and circumferential pattern. And then there is a transition from the abnormal to normal tissue, usually abrupt. So I'm going with my colon, and then up, out of nowhere, huge discrepancy between the two. And then very clear line of demarcation. How about Crohn's? The Crohn's, it has this discrete inflammation or ulceration, but usually there are going to be the skip lesion, which is like very specific for that. So here, what's a skip lesion? You all know. So this is like, you know, the everything is normal, and then this and this part is inflamed, normal, 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 and this part is inflamed. Skipping lesion is very common in Crohn's disease. This part, no, this part you are gonna find mainly the ulceration is involving this part. Here, this one is a little bit friable, but no significant ulceration. But you're right, it's really tricky one. And when I answer this question, by the way, I'm not coming up with those questions. Those are from UWorld and MaxApp. So no, it shouldn't be unique. No, you can find this and that, both. No, still. So the score is 2-1. No, 3. Who had the score? Okay. 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 First year. Unfortunately, you are gonna get it wrong. Okay. This is for everyone. Whoever is telling me the answer is gonna be, if it's correct, is gonna get it. Second, third years, if they are wrong, they are gonna be -1. So this is open for everyone. 55-year-old female coming for routine colonoscopy for average risk colorectal cancer. Is it? You're gonna find this. Oh, this lesion is very obvious here. Is it a colon cancer? Is it a carcinoid tumor? Is it a hyperplastic polyp? Is it a Meckel diverticulum?
Starting time.
Talk to your group. Okay, everyone, time is over. First year, your answer is hyperplastic polyp. Second year, you can pass if you don't know. This is my advice to you. Pass. You are not confident enough. Say pass. Colon cancer. Okay, third year. Good job, third years. Okay. Second year, good job. This is a colon cancer. A hyperplastic polyp wouldn't be like this. It wouldn't be like with an ulcer on the top. This is a mass, almost like a mass. So most cancers, this is not like a simple polyp. That's big mass. Most cancer appear as masses arising from the mucosa and protruding into the lumen. And most of them are for sure adenocarcinomas. Rarely, we just had a case. Where's Muhammad? Research fellows. Yes, we just had a case of rare one squamous cell carcinoma, which we don't see it much, but most of the time it's adenocarcinoma, usually begin in the inner lining and then progress to involve spread beyond the full thickness of the bowel, and then to the lymph nodes, and then all the way to distant metastases. So -1 to PGY1, PGY2, 1+. You guys are still at whom? Second year, yeah, you got it, definitely. No, that's why I told you, someone else with the score. No, if you get it wrong, but if you get it right, you're gonna get a +1. You deserve it. Okay. Second year, now for another -1. 31-year-old female with odynophagia, history of recent hematopoietic cell transplant recipient with EGD. Is it a candidal esophagitis? Is it CMV? Is it HSV? Is it a pill-induced? Second year. Okay, candida. Okay, how do you treat a candidal esophagitis? Treatment? You start with, yeah, the 400 and then the 200 taper. Okay. Small raised white mucosal plaque-like lesions. Risk factors is going to give you in the vignette, is it cell-mediated immunodeficiency, so AIDS or lymphoid malignancies? hematologic malignancies, especially after stem cell transplant. This is common. Or it's telling you this is like post-cytotoxic chemotherapy, or a patient who is actively using inhaled steroids sometimes without the spacer. Most common symptom of dinophagia rather than a dysphagia. Diagnosis, this is important, brushings that show a pseudo-hyphae invading the mucosal cells, and then on the culture is going to grow the candida. This is important. So although esophagitis and thrush, they can occur together in the immunocompromised patient, the absence of thrush does not exclude. So sometimes we don't have this. So we still take a biopsy, and then on the biopsy, you may find a candida. Third years. That's a 35-year-old guy coming, known history PUC. And then he's coming with a 5-day history of worsening abdominal pain, diarrhea, fever, and leukocytosis. You order a KUB, and this came back. What is this? Is it acute mesenteric ischemia, colonic intussusception, toxic megacolon, or a volvulus? Start the time. Tell me a final answer. Okay. That's correct and easy. Usually, when a patient comes with systemic findings, this is important. Fever, tachycardia, leukocytosis, this is simply takes you, this is a toxic because the patient in a toxic state with active sepsis going on, isolated colonic distension. The association in the board is going to be either IBD, it's going to give you a history of IBD, or history of C. diff, one of those. And sometimes happen with diverticulitis, complication of a volvulus, or obstructing colon cancer. The most commonly dilated areas are the right, because the right colon is kind of like a little bit thinner, and the transverse segments. What's your cutoff? This is important. 6 centimeters. Remember the number 6 for two things. 6 centimeters for the dilated colon, 6 millimeters for the CBD. CBD. Descending segment, sigmoid colon affected much less. Here, this is extensive colon distension. Who is this guy who's coming from South America again? Chagas disease, got megacolon, not this. Multiple airflow levels. Usually the Hostrom markings is gonna be like absent because of the severe dilation. Okay. Anywhere that's a cutoff, but most of the time it's gonna give you like a specific the numbers are gonna be really specified by the radiologist, but the cutoff, just remember, is 6 anywhere. But we saw like sometimes up to 8 and even like 10. It's like more than 10, 12. No, surgery has to be on board right away. Okay. Who's next? First year again. First year. Don't miss this. 58-year-old guy coming with lower abdominal and pelvic discomfort, guarding, and fever. And you did this imaging, and you are being asked about, is it a colonic ischemia? Is it a Crohn's? Is it diverticulitis? Is it a pneumatosis intestinalis? Time. Great job. Are you guys first or third years? It's okay. You're still doing great. So that's diverticulitis. This is one of the most important, like simple imaging you can see. So diverticuly and diverticulitis. So here on this imaging, you're gonna find like multiple. All those outpocketings with the air here are just diverticuli. So you can see the bowel thickening all over, but there is like increase in the soft tissue density here in those areas, but mainly the biggest ones, maybe this guy is like really big, this guy is big. Those are the big. Whenever we comment on that in the colonoscopy report, you can say small, medium, or really, really bad diverticulum. So those are sac-like protrusions ranging somewhere between 5 to 10 millimeter in diameter. The the cause of the, behind the pathology is because of the anatomic weakness where the vasa recta are like, popping up or coming out or penetrating the colonic wall, sometimes because of motility factors, due to the simultaneous or excessive haustral contractions, or some dietary problems, which we see it a lot, decreased fiber intake, people with super duper chronic long-term constipation forever, most seen where in the sigmoid or descending colon, and the increase in prevalence with age, and they most of the time are completely asymptomatic, but sometimes if they are really extensive, they may be symptomatic. They may be associated with inflammation, which is diverticulitis due to micro or macroscopic perforation. The bleeding happens when there is like a friction or abnormal mechanical irritation or exposure of this like vasa recta, and then it's gonna bleed. The bleeding happens at this gush of bleeding, and then retraction of the vessel and stops. So the patient will come to you in the ED saying, I had this 2 episodes of back-to-back significant amount of bright red blood per rectum, but now in the ED, I'm sitting like this. Where's the blood? Nothing. Okay, so this is the way it behaves. And is it painless or painful? Painless, unless it's inflamed with diverticulitis. Painful GI bleeding is thrombosis, hemorrhoid, but I mean abdominal pain, I'm saying. Ischemic colitis, this is number 1, okay? Next, second year. You guys are still on top, correct?
Yes.
Okay. Second year. 19-year-old guy with lower GI, lower GI bleed. We did a colonoscopy done by Dr. Salyers, and this is the diagnosis. C. diff, Crohn's, familial adenomatous polyposis, or that's neurofibromatosis, one where you see multiple fibrosis. Final answer? Good job. That's FAP. What I want to ask you?
Which chromosome?
FAP. APC. Okay. So no, the question actually usually comes about the timing. When do you start screening for FAP? When do you start screening? When? What year? What? We are doctors. What year? Teenagers is correct. Yes. 12 kind of. How about the HNPCC? The non-polyposis. 25. You are the man. Good job. No points. Okay. So let's review this quickly. Usually there is like, numerous amounts of polyps, 100 plus. It's autosomal dominant, germline mutation in the, who asked about the gene? That's a very good question. Adenomatous polyposis coli gene sometimes happens de novo in 25% of patients, more numerous in the distal rather than the proximal colon. The adenoma and the cancer develop in 100% of the patient. That's why it's higher risk. You start screening earlier rather than later. The average risk of colorectal cancer happens around 39 years. By 50 years, almost 93% or even higher would have 100% cancer. So what happens when they see that? They did the screening and then they find the polyposis all over. They do what? Most of the time, colectomy, total or subtotal colectomy. Then, third years, 46-year-old guy coming to you with 2 months history postprandial chest pain. Now, unresponsive to your BID PPI prescription. What's your diagnosis? Is it Barrett's esophagus? Is it EUE, erosive esophagitis, pill-induced esophagitis? And by the way, that's an EGD where you go inside, and this is time up. Answer. What are you saying? Time is stopped like 15 seconds. Say it again one more time. Which one? C. Erosive esophagitis. Great job. No, that's correct. Great job. Erosive esophagitis. This is superficial, usually erosion. Usually, you know, if you are with Dr. Salyers or Toffland or Rowe, this is, you can like, most of the time we have a classification named Los Angeles classification, Los Angeles classification, A, B, C, D, D, the worst, E, the mildest form. And this is superficial. Most of the time is due to reflux of the contents in the stomach all the way up to the lower esophagus. Might be erosive or non-erosive. The non-erosive one, we call it NERD, non-erosive reflux disease. What's the most common risk factor is obesity. Okay. First year, 46-year-old guy, history of portal hypertension. We did an EGD. What's your diagnosis? Is it esophageal varices? Is it GIST, gastrointestinal stromal tumor? Is it Mentor-Yale's disease? Is it PHG, portal hypertensive gastropathy? Timer, we have 5 seconds left. Yeah, we're gonna go with D. Portal hypertensive gastropathy. You guys are amazing. Portal hypertensive gastropathy. This is not an easy. You know, the second, third year, they didn't know the answer. Otherwise, they're going to be saying easy, easy, easy. It's not easy. Portal hypertension, what's the pathophysiology? Increased blood flow to a specific area or almost all the gastric mucosa, causing hyperemia, congestion, which is the gastropathy. When you go in with your scope, you're going to find this like white lacy reticular pattern separated by areas of pink mucosa. We call it like, it's literally like snake skin-like. It's very easy. It's either mild or severe. And mainly in the fundus of the stomach or the body of the stomach. It's a rare cause of active, really bad GI bleed. When you have like an active GI bleed in a portal hypertensive patient, you can't call this, oh, it's portal hypertensive gastropathy. PHD will present with like, you know, long-term chronic iron deficiency anemia because of the long-term oozing slowly by time. It's not going to be like the variceal bleed. Not like this. So this is important. Keep this in your mind. Don't forget it. Second, years. 37-year-old guy coming with right upper quadrant abdominal pain. Painful. Immigrated from Guatemala 5 months ago. We did a CT. Is it an FNH? Is it hepatic abscess? Is it hepatocellular adenoma? Is it a necrotic hepatocellular carcinoma? And sometimes it gives you like some sort of information to sway you away from the answer. You know, sometimes it's tricky. Usually UWorld does that. The ABIM does that. You know, it gives you like, oh, it's really coming from Guatemala, you know? Their number, but you're out of time. It's me. It's me, but maybe okay, so it doesn't look like, you know, this HCC, hepatocellular carcinoma, which is irregular with necrotizing center or something. You don't agree? Hepatic abscess. What's the treatment of this? You call surgery in order to... Yes, metronidazole. Good job. Hepatic abscess. Amoebic abscess on the CAT scan, heterogeneous. It's round or oval with irregular margin. Possible peripheral contrast. Sometimes it has internal septations, which makes it difficult, especially sometimes the IR would drain. Usually this is not drain. It's just IV antibiotics. Found in developing areas of, you know, someone migrating from South America or so, intestinal infection with amoeba, usually invade the portal vein and then migrate to the liver. Symptoms, it's painful. The HCC most of the time is painless. Symptom, and then the treatment is IV metronidazole. Don't choose surgery. This is a common mistake. Go ahead, Bob.
So do we need to get people sample for fever and
So
check it?
this patient is not presenting with diarrhea even. Yeah, sometimes if the patient is presenting with dysentery, blah, 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 one of the routine orders is going to be the stool panel. Now they have this like a GI panel, unlike before, open parasite, blah, blah, blah. No, now they have it's like, multi-PCR thing, all in one order. Third year, 47-year-old guy, chronic abdominal pain and diarrhea. IgG4 is normal. They did a CT, frontal CT scan. Diagnosis is it autoimmune pancreatitis? Is it chronic? Is it the intraductal papillary mucinous neoplasm, which we call it IPMN? Or that's a pancreatic ductal adenocarcinoma. I can see it.
Now we started chronic because of the
Everyone agrees? Yeah. Okay. Good job. That's simple one. Usually someone in step one would do it. This is like chronic calcification, very easy, simple, to the point. Chronic coarse calcifications in the body and the tail. Diagnosis sometimes as a chronic pancreatitis, usually it's really challenging because yes, the pancreatic calcifications helps you, but they are only present in 25% of patients. So other findings like atrophy, like ductal dilation, which may occur in even like normal people. So nothing pathognomonic for chronic pancreatitis. Most of the time we are going to ask someone to do an EUS or for further characterization, or does just MRI and further imaging. So the CT or MRI, the initial tests are choice. First year, now for another point, 79-year-old guy, crampy lower abdominal pain, followed 24 hours later by bloody diarrhea. Dr. Salyers did this colonoscopy and asking you, what did he see? Is it C. diff, colitis? Is it colonic ischemia? Is the Crohn's or UC? Amazing. Colonic ischemia, stop complaining. Colonic ischemia, due to reduced blood flow most of the time. It's mainly in the watershed areas of the colon between perfusing vessels. What are the watershed areas? Splenic flexure, one. Rectosigmoid. How about the rectum? Do we see it like common? Why? Dual blood supply. Perfect. Acute colonic ischemia, rapid onset mild cramping, abdominal pain, and tenderness over the affected bowel. Variable amounts of bleeding within 24 hours whenever they had the pain. Later on, I was sitting on the toilet and then out of nowhere, boom, boom, back to back. Acute stage, the mucosa usually are frequently pale, areas of petechial bleeding here and there. When they get worse with more and more ischemia, the hemorrhagic ulceration will happen, and then you'll see those bluish nodules. Can you see this on the colonoscopy? Can you see those bluish nodules here in those areas? Why that? Because of submucosal bleeding, mainly venous in origin. They are very equal. These bluish points are very equal to, when you do a CT scan, a CAT scan, it's showing the thumbprint sign. So this is an equal finding on colonoscopy, on imaging. Okay, second year, you are sitting at your boring PCP clinic, 47-year-old guy coming to you. I have severe rectal pain with passage of stool. The pain began abruptly after passage of large hard stool. This is my perianal exam. And what's going on, sir? Is it anal fissure? Is it HSV, simplex infection, with this small vesicles here, as you can see, or that's an ulcer in the middle, or this is like a hemorrhoid that got thrombosed and becoming like more and more painful? Fissure. Okay, that's a fissure. That's a fissure. How do you treat that? How do you treat it? Sits bath. Good job. Okay. Acute anal fissure. Most of the time they are longitudinal tears along the anal canal. Okay. Usually the most common site is the posterior wall and comes with anorectal pain. Whenever there is a bowel movement, especially if the guy's constipated, is going to get worse. May come with rectal bleeding with the bowel movement or mainly with the wiping. It might be idiopathic, might be traumatic due to a passive heart stool. Those guys who do receptive anal intercourse, any mess sometimes, make sure sometimes, a nurse who is not very skilled, she may cause like a tear because of the wrong way of the enema application. And then finally, endoscopy, hopefully we don't do that. Look at this first year.
It's a tough one, so it's not for the first year.
56-year-old female, history of alcohol use disorder, large volume hematemesis. Dr. Toflin did this EGD, and we found this. Something is it a cancer? Is it a esophageal varix that's like oozing blood? Is it a gastric ulcer? Is it a pill-induced esophagitis? Who's answering? Varix. Yes. How do you treat it? What is this? Yeah, usually most of the time you're gonna apply some epinephrine injection so that it you get like temporary transient hemostasis, and then you get your clip and apply the clip right away over. Okay. Varices. But by the way, this one, that's a gastric varix. Okay. So if this if it's esophageal varix, sometimes you do that, but most of the time you can do mainly the management of esophageal varix, as you know, it's like banding, either prophylactic or therapeutic sometimes. But again, this is like a spurting like varix in front of you, which is sometimes like if I'm doing this, I'm gonna be scared to death. But usually when you have the attending by your side, you don't care. You're just, playing. You have someone like supporting you. Yeah. Varices, a large vessel within the lumen of the lower esophagus, extrahepatic pathway of blood, because of the increased portal hypertension. And then over time, the varices may enlarge and may they spontaneously bleed. If this is for patients with cirrhosis, before they bleed, what do you start any kind of medication to help them to prevent bleeding, primary prophylaxis or secondary prophylaxis sometime after they bleed? Not octreotide for prevention of bleeding. Beta blocker. Good job. What kind of beta blocker? Yeah, mainly the most important that was proven to be the best is CoRAG. You start with a 6.25 milligram once daily, and then you go up later as tolerated, as long as the patient is not bradycardic, hypotensive, reporting like headache to you and stuff. Okay, first year. 48-year-old guy coming with an abdominal pain. He's telling you, I have a previous history of sclerosing sialadenitis, which is inflammation of the yes. Did a CAT scan. What's your diagnosis? Is it AIP, autoimmune pancreatitis? Is it interstitial pancreatitis? Is it necrotizing, as we spoke before, or that's a pancreatic islet cell tumor?
All in favor? A. Yeah. A.
This is simple, mainly because, he's reporting this sclerosing sialadenitis. What is this? What do you see here? Anyone is hungry? Autoimmune pancreatitis. Imaging, that's a narrowed main pancreatic duct with the parenchymal swelling all over, just like a sausage-shaped pancreas. What do you order for this? What kind of IgG? IgG4. There are two types, autoimmune pancreatitis 1, 2, and the drug induced is type 3, AIP type 3. which we usually we don't see it much. The only time I saw that muddy was a patient on one of the ICIs, a patient Dr. Trung, and it was even suspected, but usually not sure if that's common or not, but I haven't seen any of the type 3. Significant elevation of serum IgD4 help diagnose you. Type 1, elevated levels of IgD positive. This is on the pathology, more than 10. The number is important. So the associations are really important. Sclerosing cholangitis, sclerosing sialadenitis, and then the retroperitoneal fibrosis. PGY2, 65-year-old female, history of osteoarthritis, coming with an epigastric pain. On a CBC, you find significantly microcytic anemia. You got iron studies, iron deficiency anemia. Dr. Rodo did this EGD and is asking you at the endoscopy suite, what's your diagnosis? Is it acute hemorrhagic erosive gastropathy? Is it that Dulafoy lesion, which you can see it from here? Gastric angiodysplasia, peptic ulcer disease. Final answer? Final answer? A. And did you get a chance to look at this?
Can we try to take their questions first?
No, they are the low, they have the lowest score, so we're trying to help them as much as we can. If they got something wrong, so we're trying to help them. Think again, think again. Think again, PGY2.
Yeah.
Final answer is good job. That's a peptic ulcer disease. Okay, I'm gonna try to help you. Can you spell Dulafoy for me? You're gonna get a point if you got it right. Say it again. You have the pen here. Quickly. If you want to write it down, you're gonna get a point. Okay, nobody wants to? Pass? Pass, okay. You are a PGY3. Okay, how about that? Go ahead. DE. No. No. It's DI. But the problem with the Dulafoy lesion that it has all the vowel letters you may even think about. Dulafoy lesion. No. Okay. This is tricky. When I tried to do it, I answered just like you. I got it wrong as well. I thought might be erosive gastropathy. This is here. Where are we here with this stroke? He is going past the function, and then this is the pyloric antrum, and then when you go in, this is gonna be the ball, correct? So this is a peptic ulcer disease. This is inflammation in the pre-pyloric area. That's the pylorus entering the D1, and then this is here a shallow ulcer. I'm not sure if the light is here in the upper left at 10 o'clock. For gastritis, make sure that you know it's gonna be like mucosal erythema or edema. Some erosions might be there due to disruption of the normal mucosal barrier. For benign ulcers, they are usually smooth, regular, rounded edges, flat, smooth ulcer base that's often filled with exudate. PGY3. 57. Whenever you say stop, I'm gonna stop. Stop now. Last question. 57-year-old female. What time is it? Oh, sorry for that. 57-year-old female, chronic Hep B, recently discovered hepatic abs with a hepatic mass. A CT scan with an arterial phase was done. What's your diagnosis? And I believe the lesion is here, maybe here.
5 seconds left.
Amoebic abscess, echinococcal hiatus cyst, hepatic metastases, or epithelial carcinoma. Great job. That's HCC. HCC diagnosis. Usually the 4 phase is really important. This is like very specific, EV arterial phase enhancement. This is important for HCC. So just before you go, I know you don't have time, but just, quickly spot diagnosis, because those are really important for your test. This is the guys doing retroflexion and seeing this coming with MSS. This is a Mallory Weister, good job. And then for this guy, what is this? Web or Chatsky ring? Chatsky ring. Screw over. Okay, how do you treat it? Dilated, good job. What is this? This is diverticular bleeding one as well, with some like, okay, good job. And here are the pictures. This is, we spoke about how do you see diverticular imaging. What is this? That's a guy with GERD. You're going in the esophagus. That's Barrett's esophagus. Good job. Don't forget the same colors, mucosa. And then that's an ultrasound in the ED. Guy, lady coming with a abdominal pain, right upper quadrant. What do you see here? This is the gallbladder, and those are like few, like teeny tiny stones with shadowing reflections. That's a gallstone, simple and easy. What do you see here? That's an perianal exam. Yes, good job. Crohn's disease, very fistulizing Crohn's disease. Good job. And as you can see here, bleeding in of fistula. This guy and this guy. Sorry. And the skin tags are usually common. It may come in different forms. In the vignette, it might give you a recurrent polymicrobial UTIs, meaning that's enterovesical, and the enterovaginal or enterocutaneous, like this guy. And this one, muddy. This one is important. This is the other one. This is abdominal pain, weight loss, lytic colonoscopy. And then you can find the lesions here. This is Crohn's disease because of the skip lesions. Good job. This lady is a normal. This is actually not cirrhotic patient. That's a patient gravity 1 para 0. I'm doing fine. I'm not cirrhotic, doctor. Okay. Yes. Any high estrogen state might code this. So you're right. Sometimes it's on the ITE exams and stuff. Spider angiomas. This is very common. This is what? This is a Sherry hemangioma, which is the difference is very important. When you press on it, it doesn't blanch. It doesn't blanch. The bed bugs are bed bugs most. What is this? Finally, a history via ulcerative or Crohn's, pyoderma gangrenosa. Most of the time is going to be next to the ostomy. This is like really common side. So association is going to be either a history of IBD or hematologic malignancy like AML. Final one, or maybe before final, that's an MRCP, a guy coming, history of UC. Great job. That's primary sclerosing cholangitis, intra and extra. Yes. And where is here the really bad stricture?